My topic is MRI patterns of nerve root enhancement in Guilian Barre syndrome, a retrospective clinico-radiological case series of 13 patients. First author is me, Dr. Shubham Adate. Co-author is Dr. Prashant Naik, Head of Radiology of Department of Kashibai Naule Medical College and General Hospital, Pune. Second abstract is basically GBS background and purpose. GBS is most common cause of acute flaccid paralysis worldwide. Contrast enhanced MRI is a supportive diagnostic tool, particularly when electrodiagnostic and CSA findings are equivocal. We describe the spectrum of nerve root enhancement patterns on a MRI in a cohort of 13 patients with clinically suspected GBS. Method is retrospective review of 13 patients referred with acute bilateral lower limb weakness. All underwent gadolinium enhanced spine MRI. Enhancement pattern were graded as subtle, prominent, and enhancement plus thickening. Thickening only or normal. GBS disability score days from onset to MRI. CSF protein and nerve conduction subtype were recorded. Results were 12 out of 13 patients, 92.3% showed positive findings. Subtle enhancement was most common, 46.2%. Followed by enhancement with thickening 30.8%. Anterior nerve root enhancement, nerve roots were predominantly involved 84.6%. Cauda equina predominance was noted 76.9%. 9%. Prominent enhancement correlated with higher GBS disability score at admission. Conclusion was contrast MRI with fat saturated sequence have higher sensitivity in GBS, which shows a consistent anterior nerve root and cauda equina predominance. Prominent enhancement may indicate more severe initial disability. Contrast is mandatory, especially non-contrast sequences are essentially normal in GBS. Introduction is GBS is an acute immune-mediated polyradiculopathy, most common cause of acute non-poliovirus, acute flaccid paralysis globally. Incidence is 0.8 to 1.9 per 100,000 per year. Pathophysiology is molecular mimicry following infection, anti-ganglioside antibodies, disruption of the blood-nerve barrier, inflammatory nerve root edema, and enhancement on contrast MRI. Subtypes are AIDP, acute motor axonal neuropathy, AMAN, and acute motor and sensory axonal neuropathy, AMSAN. Miller-Fisher syndrome, anti-GQ1B antibody. Diagnostic role of MRI. MRI is recommended when nerve conduction studies or CSF analysis are equivocal to exclude mimics, compressive myelopathy, transverse myelitis. Non-contrast sequences are essentially normal. Gadolinium is mandatory. Leonard et al. By 2019 study literature review. So study design is retrospective case series, study period from 2019 to 24. Setting is tertiary care teaching hospital, Kashibai Naule. So ethics approval by SKNMC, Kashibai Naule Medical College Institutional Review Board. Inclusion criteria: acute bilateral lower limb weakness, clinical suspicion of GBS, Brighton level 1 to 3 criteria met. Gadolinium, complete gadolinium enhanced MRI spine. Exclusion criteria is known malignancy or HIV, incomplete MRI study. Alternative final diagnosis confirmed. MRI protocol on 3T or 1.5T. Sagittal T2 is whole spine survey, cord signal present. Sagittal T1 post gadolinium enhancement, which shows nerve root enhancement. Axial T2 FS is lab root morphology at cauda equina level. Water axial FS 3D contrast, fat saturated post gadolinium key sequence. Enhancement graded, absent, subtle, prominent, thickening only. Patient characteristics are given as follows. Patient age, sex, antecedent, and basically disability GBS scores, and days to MRI and CSF protein, NCS nerve conduction subtype, which is demyelinating, equivocal or axonal. MRI pattern is given, which is prominent plus thickening of the cauda equina nerve roots or subtle enhancement. In this table which are given, only one patient has basically normal MRI findings, or antecedent cause may be upper RTI, GIT infection, or recent vaccination. Diagnostic criteria, say basically 13 patients enrolled in GBS, suspected GBS. MRI were positive in 12 patients, 92%. Mean days to MRI were 11.5 days, 5 to 21 days. Range, mean CSF protein is range is 44 to 115 milligram per deciliter. 79 milligram per deciliter. Range is 44 115 milligram per deciliter. Brighton diagnostic criteria, which basically criterion is bilateral flaccid limb weakness, decreased or absent deep tendon reflex in weak limbs, monophasic course, onset nadir, CSF protein basically more than 60 or cells less than 50 milliliter. Nerve conduction study consistent with GBS subtype. Say level 1 is present in all of them. Level 3 only bilateral flaccid weakness, decreased DTR, and monophasic course is present in level 2 and level 3. CSF may be present in level 2 and level 3, but it is always present in CSF, and nerve conduction is always present in level 1. The MRI findings is basically no significant findings in one patient, which is 7.7% as per the pie chart. Mild thickening only in two patients, which is 15.4%. Enhancement plus thickening is seen in 4 patients, 30.8%. So subtle enhancement only in 6 patients, 46.2%, which is majority. So only 1 out of 13 patient has a normal MRI. Sensitivity of gadolinium enhanced MRI in this series is 92.3%, consistent with Gaussen et al. 83% and Bune et al. At 100% in published literature. Say imaging gallery, in this is on the left side we see the sagittal T1 post contrast images, which shows cauda equina thickening clearly, and on the right we also see a sagittal T2 image which shows the cord signal, and parenchyma, which confirms the peripheral nerve root pathology. This is an axial T2 fast spin echo slab at the cauda equinal level, which shows the on the left side, which shows the bilateral symmetrical nerve root morphology at two sequential cauda equina levels. So note the symmetric distribution of the intrathecal roots, which are basically with intrathecal roots. This is a water axial FS 3D contrast fat saturation post gadolinium enhanced, which shows the eliminates the fat signal and maximizes the conspicuity of the anterior nerve root enhancement, which we can see clearly in the left image of the anterior conspicuity of anterior nerve root enhancement or cauda equina. This is the most sensitive single sequence for GBS diagnosis. Axial FS 3D contrast image. Results are basically any nerve root enhancement which is 12 present is basically 92.3%, 83 to 95 by Gaussen. Anterior is nerve root enhancement is seen in 11 patients, 84.6%. Posterior nerve root enhancement is seen in 3 patients, subtle enhancement only in 6 patients. Enhancement plus thickening in 4 patients. Cauda equina predominance is 10 patients, which is 76.9%. Normal MRI is seen in 1 patient, so 7.7% out of 13 people. So 13 cases. Results are basically clinical radiological correlation. The MRI pattern enhancement plus thickening, which is prominent thickening. Number of patients were 4. So the mean disability score was 3.5. Mean CSF was 101, and mean days to MRI was 7 days. Subtle enhancement only in 6 patients, 2.3 mean disability score, and mean CSF score was 77, and mean days to MRI were 14.5. Thickening only, no enhancement, number is 2. So mean disability score was 2, and mean CSF fluid protein is 65. So mean days to MRI was 19.5. Normal MRI is seen in 1 only. So mean disability score was 1, and CSF was 44. So prominent enhancement plus thickening was associated with higher GBS disability score at admission, mean 3.5, consistent with Gaussen et al., who found her higher disabilities, prominent disability grades in prominent enhancement groups. Earlier MRI, mean 7 days from onset in prominent groups, suggest a more aggressive early disease, prompting earlier imaging. The normal case discussion: patient 13 was a female, 31 years, no antecedent illness, GBS disability score of 1 at admission, CSF protein was 44, borderline equivocal nerve conduction study was done. Nerve conduction study. MRI was performed day 12 from symptom onset. MRI was normal because patient had mildly clinical presentation, GBS disability score of 1, borderline CSF protein. Mild GBS may not produce sufficient disruption of the blood nerve barrier to cause gadolinium leakage detectable on MRI. What does the literature say? Gaussen et al. Reported normal MRI for in 4 to 24 patients, predominantly variant presentation and milder disease. Does MRI negativity does not exclude GBS, particularly early in or mild cases. So repeat MRI must be performed if clinical suspicion remains high. Clinical outcome is basically the patient recovered to GBS disability score 0 within 8 weeks after IVIG therapy, supporting the diagnosis in retrospectively. So differential diagnosis are CIDP, basically neurosarcoidosis, infectious arachnoiditis, leptomeningeal carcinomatosis, and AIDS-related polyradiculopathy, Lyme, neuroborreliosis. Discussion is basically interpretation. Is 92.3% MRI sensitivity, validates contrast MRI as a frontline tool. Our positive rate aligns with Gaussen et al. and Bune et al. Supporting gadolinium enhanced MRI at a higher sensitivity adjunct in clinically suspected GBS cases. Subtle enhancement is the dominant pattern, 46.2%. Fat saturation is non-negotiable. Nearly half of the positive cases show only subtle enhancement, which would be missed on without fat saturated post-contrast 3D sequences. This reinforces that protocol design determines directly diagnostic yield. Anterior nerve root predominance. Anterior root predominance reflects acute demyelinating polyradiculopathy pathophysiology. The predominance of anterior root involvement is consistent with AIDP subtype, correlating with bilateral ascending motor weakness. Posterior root involvement was associated with sensory symptoms. Prominent enhancement indicates severe initial disability but does not indicate long-term outcome. So higher GBS disability score at admission time correlates with the prominent nerve enhancement, consistent with Gaussen et al. However, enhancement grade alone does not predict long-term functional recovery. Conclusion is gadolinium enhanced MRI has 92.3% sensitivity in clinical suspected GBS. It should not be performed. It should be performed routinely, especially when nerve conduction studies and CSF findings are equivocal. Fat saturated post contrast 3D sequence, water axial FS 3D contrast are essential. Subtle enhancement, most common pattern is missed without fat suppression. Anterior nerve root enhancement and cauda equina phenomena are hallmark findings reflecting acute inflammatory demyelinating polyradiculopathy predominant subtype and is ascending motor neuropathy. Prominent enhancement correlates with higher GBS disability score at admission but is not a reliable predictable of long-term functional outcome. Normal MRI does not include GBS, especially in mild or early disease. Repeat MRI should be considered in clinically compelling cases with initial negative study. These are the references for this.